I would like to say that PIH is a topic that there is not too much study about it. There is a complication of inflammation in acne, but there is not too much research about it. So we are starting to try to understand what happened with this problem. In many patients prefer acne instead of spots. Tell to the doctor, oh, doctor, I'm fine about acne, but I have spots and I don't like it. It has an important psychosocial impact. So I think the most important about my talk yesterday is that there is two types of PIH. And we don't know why there is patients who develop only in the surface of the epidermis, the pigmentation, and there is another group of patients who develop dermic that is more deep, like a tattoo, and it lasts a lot of time, and this is the most difficult to treat. So when a patient have post-inflammatory hyperpigmentation, some new concept is that you have to know where is the level of the pigmentation for prognosis and choose the treatment. If I have a superficial, I have one approach, and I have a deep pigment, I have another approach, and the prognosis is different totally. So it's important to know where is the the pigmentation. But we don't have too much resources in the practical life. We don't have technology to know where is the level. There is cross-polarized photo pictures. There is ultraviolet rays pictures, the other possibilities, confocal dermatoscopy, etc. But in general, the clinic is important to know the color of the skin. If you have a light brown or brown, it's epidermal, and you have a gray, blue color, maybe it's dermal. But for sure, a biopsy, a little biopsy, 2 millimeter sponge, sometimes is necessary to know where is the level and to give the patient much better information about the future and the prognosis of the treatment. I think this is an important issue today to know where is the level, and the treatment and prognosis is different depending of the variety of the PIH, or the post-inflammatory hyperpigmentation in acne. It's absolutely important because, as I told you, the prognosis and the treatment is different. If I have an epidermal pigmentation, post-inflammatory hyperpigmentation, I can use topical retinoids. I can use bleaching agents like kojic acid. Hydroquinone I don't like too much. And there is a mistake in many of my colleagues. If you have a pigmentation that is in the dermis, hydroquinone will not work. And if you use for a long time, you will provoke other problems, more pigmentation, achronosis, and hydroquinone in high concentrations cause irritation. So this is a vicious circle in that the patients don't improve and use for a long time hydroquinone, for example. So it's very important to know that if you have a dermic PIH, maybe the most important treatment now is technology. We can use lasers, Q-switched lasers, for example, picoseconds or nanoseconds that destroy the melanin. And this is very interesting because our photoacoustic lasers, the noise is high. You do listen, the laser, so the sound is destroying the melanin, and the light is destroying the melanin in the same time. So the use of lasers in the dermic level is more suitable, or it has a rational, more with much better rational than use creams or something that, because dermal is like a tattoo. So there is this concept that the level is very important for determine the treatment and the prognosis. Otherwise, now we have oral drugs that works well for the PIH. However, the problem is that these drugs are used in Asia, for example, or in Latin America, but are off-label, but works fantastic, like tranexamic acid. And there is not approved for FDA, and it's used in the United States off-label for the treatment and prevention of the PIH in many clinics. If you will do laser epilation or you will do some treatment, peeling that cause injury in the skin, and you see the patient is a high-risk patient for develop PIH, you can give preventive tranexamic acid by mouth. But there is not clear the dose, there is not clear the mechanism, but in clinical practice works very well. So maybe there is necessary that some company do studies or sell the drug, but with the approbation of the FDA or something like that, for to be more safe or security that we are doing well the things. But in practical, there is enough information that it could be used for PIH and for melasma with good results, together with the topical treatment. And the technological resources is an dermical pigmentation. I think this treatment is very important for the future. I'm speaking about tranexamic acid. We need a lot of research, we need a lot of papers, we need a lot of evidence, but this drug is the future for melasma and PIH, since my point of view. It's like isotretinoin in acne. This is a very effective drug, and there is a meta-analysis with 22 papers and almost 50,000 patients that shows the side effects are not important. There is no thrombosis in venous or arteries. It's very safe drug, but we need to do the things more legal, well, to do a much better treatment. But this is the future. The other part is the technology, that we are using new nanoseconds or picoseconds lasers that are photoacoustic treatment for destroy the melanin. And the most important in acne is the prevention. If we have patients that are high phototypes, dark skin, and you have a patient who is 12 years old, for example, who start with acne, you start the treatment ASAP, as soon as possible, avoid an inflammation for avoid the upsurge of PIH in the face, for example, or in the back, that the people don't like the spots in the body.